Thank you, Dr. Castro. Next, we're going to have Dr. Mark Lavallee speak to us. Dr. Lavallee is the Regional Medical Director at the Central PA region for UPMC. He's also faculty for both the UPMC Pinnacle Sports Medicine Fellowship as well as the Drexel University Department of Family Medicine. He also serves as the chairman of USA Weightlifting Sports Medicine Society as well as a member of the International Weightlifting Federation. And I believe his talk is going to be on the orthopedic considerations in patients with familial aortopathies.
So I'm probably the least knowledgeable person that's speaking to you today. I've just enjoyed listening to Kim Eagle and Dr. Castro and Dr. Sultan for the invitation to speak to you. My background is I'm just a family physician and a sports medicine doctor. Okay, so my hobby is working with patients with connective tissue disorders, and I've only been doing it since 1998, I believe. And I'm basically run an EDS, Marfan's Osteogenesis Imperfecta clinic in Central PA in Harrisburg currently. I have no really conflicts of interest other than I'm volunteer relationships with some international Ehlers-Danlos work groups, the USOPC, Olympic Training and Paralympic Committee, U.S. Weightlifting, and I'm on the executive medical board for the National Weightlifting Federation in Switzerland. I'll try to go as quickly as I can. I aim for 20 minutes, and I should try to make this. My slide deck will be available for everybody. We'll go over the most recent New York, we call it New York classifications, which we met in New York City, 80 of us researchers. We'll go over the brief history of EDS. I'll probably blow through that, get to more of the clinical features, diagnostic testing, and then of course rehab and treatment, which is where I spend most of my time with my patients. Big issue with Ehlers-Danlos and even with Marfan's is they're getting harder and harder to get in to be seen with medical genetics, and that's been a huge problem in the last 3 to 4 years. So about 40% of my patients will come to my clinic with a diagnosis of possible connective tissue disorder, and 40% will not meet the criteria, the Ghent criteria or the New York classification. We'll try to get them the help they need, and I can get into a little bit why we're seeing this increased interest in connective tissue disorders. We'll talk about some research that's coming up, that we have a paper in hypermobile type EDS where we believe we found the protein and genetic defect for it that will be has been accepted by the New England Journal and will be published here in the next couple of months. If we have time, we'll get into the actual some interesting cases. So not all hyperflexible athletes have connective tissue disorder. So my interest sort of spans a couple components. I started noticing as a sports medicine physician, first with the University of Notre Dame, and then most recently with Gettysburg College and with the Olympics, that there were some patients that were very, very, we call it, say, hyperflexible. And they did not have a connective tissue disorder. In 2015, I was the chief medical officer at the Pan Am Games in Toronto, and Cirque du Soleil did our opening ceremonies. 120 acrobats, just like this Michigan State cheerleader or baton acrobat, would have these high Beighton scores, but have no pathology, okay? And then, not all patients with connective tissue disorders will have pathological flexibility. So it's really hard to find these patients and discern if they have this. So we'll go back in May of 2016, I was one of 7 Americans that were invited to this international symposium to help work on the nosology for Ehlers-Danlos syndrome by the Ehlers-Danlos Society. The Ehlers-Danlos Society is an outgrowth of the Ehlers-Danlos National Foundation, which merged with the British counterpart, and now this is an international foundation based out of London, with offices both in America, in DC, and in London. So here's a group of us, and they're much smarter people than I, clinicians, researchers from around the globe working on, the science behind Ehlers-Danlos syndrome. And here's the paper that the paper that we came out with that came out in March of 2017, American Journal of Medical Genetics. And I won't belabor this. You guys can all look at this, and it's quoted in my bibliography. We revised the old nosology. Okay, this is where everything was using Roman numerals. There was only 12 types of EDS recognized at that time. and they chunked them into 6 major categories. And you can see the more common, classical hypermobile vascular, and then the very rare, oculosplerotic arthrochalasia and dementia praxis. As of 2016, there's 14 different subtypes. We're going to keep this very tight for this talk since I have a very limited time to speak to you. That 85% of those with Ehlers-Danlos syndrome, okay, will be the hypermobile type. These are absolutely normal-looking individuals that have a whole host of issues. Some of them is joint-related, some of it's histamine-related, and some of it's vascular stability-related or dysautonomia. The classical type and vascular type, which make up 10 and 5%, have dysmorphic features that make them easy to sort of diagnose. Okay, we won't get into the rare forms here due to time. One of the things that that has been bantered around for quite some time, Howard Levy, myself, Rodney Graham out of England, a rheumatologist, Brad Tinkle, a medical geneticist, and then Howard Berg. The difference between joint hypermobility syndrome and hypermobile type Ehlers-Danlos. There's a lot of controversy. So those of us in the world we work in prefer to use the term hypermobile type Ehlers-Danlos versus joint hypermobility. They do have the same ICD-10 code, so it makes things really confusing. So what is Ehlers-Danlos syndrome? It's a group of heritable disordered, an inheritable or heritable disorder that affects the collagen, often characterized by joint hypermobility, skin hypermobility, bruising, and skin fragility. When we get to the vascular type, there's a beautiful paper out of Rick Weinstrup out of University of Cincinnati, which looked at the aortic component. We'll get to that in a second. This goes back to Van Meerken, and who was a Dutch surgeon. Here's a lithograph of from 1682 of a Spaniard that could stretch his skin to his cheek. And they call this Chernobyl syndrome in Russia, not Ehlers-Danlos syndrome. One of the most interesting parts that was interesting to me is in 2014, I was the chief medical officer for the IWFO Masters Championships in Copenhagen. So every day I'd walk by this old hospital, Emiger Hospital, and this is where Evard Ehlers diagnosed the first patient with EDS. Walked by it for a whole week until I realized where I was walking by a very historic place. Here's Evard Ehlers and Ehler-Danlos over 10 years ago. Here's the interesting thing about this picture of the first known patient from 115 years ago. Look at not just the skin, look at the collapse of the hand, look at the dislocation. That's his olecranon facing forward, and his hand is externally rotated, so he's auto-dislocated his elbow. And he said this was a variant of cutis laxa. Okay. This wasn't really given a name until 1949. It was not known it was a genetic a collagen defect in 1955. And Peter Buyten out of South Africa gave it the heterogeneous transmission of mostly autosomal dominant with a few excellent components. The Ehlers-Danlos National Foundation wasn't started in 1985. Nosology wasn't diagnosed until 1998. So this is, we're all sort of new here. And Dr. Kim Eagle said it, the aorta, and William Osler is very, we're learning. We really don't know what we're doing. And I would say the same thing with Ehlers-Danlos syndrome and all the stuff we're learning about how it affects mitral valves, how it affects the aorta in EDS and in Marfan. Victor Mukuzic, who received an amazing award as the father of modern medical genetics out of Hopkins, practiced to the ripe age of 92, I believe, 97, excuse me. So, if you ever think of retiring, doctors on this case, I mean, this guy just kept going. Amazing what he did for those of us with Mendelian inheritance of man. We won't go into all the famous people that may have had EDS. Nicholas Pagnini, who's called the devil incarnate, the rubber men of India, who actually weren't from India, they were from Romania. People like Sia, the musician, Jamila Jamar, British actress, all have EDS. So it's very important with the clinical diagnosis, which is still the way we start with all this, is that history is super important, getting that genogram, looking at that history and trying to decide do they meet this criteria. There's a bunch of things we look at. We look at, a lot of the history is, do these things happen? Have they had an aortic aneurysm, aortic dilatation, premature rupture of their, rupture of the uterus during third trimester pregnancy, spontaneous pneumothorax, and diverticular spontaneous rupture of the bowels. All these, we're looking at an age component. We like to see this before the age of 40. If we see it over the age of 40, there's a lot of concomitant diseases, that cause aortic dilatation, right? Obviously, smoking, diabetes. So we fight a lot of Munchausen's, child abuse, fasciitis aorta, fibromyalgia, psoriasis. It's amazing the different diagnoses, sometimes correct, sometimes incorrect. Here's an example of what people would call psoriasis, but this is the cigarette paper scar tissue that you see with classical type Ehlers-Danlos syndrome. So we start off with the face. How do we recognize people? It's through our face, what we look at every day, right? That face is Castor Medina. I know what his face looks like. Mark Lavallee, whoever we are, our face, our voice, our handshake. So we're going to focus on the facial components. Prominent scars on the cheek and chin that have a trophic component, epicanthal folds, very flexible skin. You can see in this picture, this was actually on the cover of Penn State Health. I got this way back in medical school. And you can see the swan neck deformity of the patient's patient and some female's hands pushing this patient's face together. You can see on the very bottom picture, this face is with with vascular type, prominent cheekbones, wide-spaced eyes, prominent lop ears, thin, delicate nose, hollow cheeks. Okay, here's the blue sclera that you see common. Only about 10% of people with EDS will have the blue sclera, but when you see it, it's quite impressive. The hand, we shake hands all the time. We used to before COVID. But when we used to shake hands, I could feel the collapsible hands clasp when I shook someone's hand. You can see the double joint, the greater than 90 degrees of hyperextension of the pinky, the auto dislocation of the shop thumbs, and you can just feel this in the hand. The scars are pretty prominent, specifically in classical and vascular type. It's really hard to miss the pretibial scarring, the translucent skin, the cigarette paper scar tissue. When you start looking at vascular type, which is about 5% of the patients that I see, I've probably seen about 3,500 patients with EDS and probably about 50 patients with, maybe 50 to 75 patients with Marfan's over the years. You'll get what a lot of people will think, oh, well, this is just varicose veins. No, actually, when you start tracking it out, you'll see this translucent skin on top of this. And here's a great example of that translucent skin. You can see this in caucasoid patients and also patients with deeper pigmentation, but you really look for it. It really looks see-through. Okay, this all occurs before the age of 40, and here's what we're looking at. We look at aortic root and descending 45% aneurysm, 35% will have aneurysms in the cerebral arteries, and then 10% will be in the vertebral arteries. Spontaneous pneumothorax. When we look at the aorta and aortic problems, Rick Weinstrup, and I didn't have time to put this in, Rick Weinstrup paper out of, I think, 2001, looked at the incidence of aortic abnormalities. So this is dissection and dilatation and aneurysm in non-vascular type EDS, specifically looking at classical and hypermobile type. And at the time, VDES in his paper 21 years ago showed about 90% of VEDS had some sort of aortic abnormality. Classical type had 44% to 40 to 44% issues with the aorta, and then hypermobile type had about a 20 to 26%, so much higher than the average population. You can see when we move to the skin extensibility, you can see this at neutral sites, the elbow, the angle of the jaw. This gentleman here with the yellow-green hair was a patient of mine who went to States in Butterfly as a high school student that had Ehlers-Danlos syndrome. When we look at the floppy foot, this excessive subtalar motion is another thing that's really interesting. I find this when I'm walking on the beach and people are laying in a supine position and their feet are at 90-degree angles, and sometimes even interlock their fingers like people interlock their toes. Excessive is very, very common. It's one of the ways to tell. Here's some of my patients internally and externally rotating their hands in different directions. We talk about the Beighton score, and I'll talk briefly about this. This is the key thing. If no one else remembers much about my talk, please remember the Beighton score, because this will give you the key of, are they double jointed? Okay, so it's a 5 out of 10. This used to be called the Carter-Wilkinson criteria, but we give Peter Beighton the most of the credit. So if you look at the top left picture and the middle picture, you can see the hyperextension at the MCP joints of 90 degrees. If you look at the document we wrote and published in 2017, it was basically the fifth finger, okay? So the hyperextension of the pinky. But when you really, really dial it down, a lot of people can do that and they can't do their index finger or the middle finger. So I look at all the things. The second is forward flexion of the thumb to the forearm. Okay, you get a point for each pinky or hand finger and point for each thumb. So that's 4 points if they can do both. Okay. The next would be hyperextending the elbow greater than 10 degrees. And here's an example. I don't have a goniometer here, but you can see the elbows are going the wrong direction. With Marfan's, you're going to have more of a carrying angle. So I see that commonly when I see my Marfan's patients versus my EDS patients, that elbows go one direction with one and the other with the other. And also, there's other things with, again, criteria that we're not going to back to. When you get to the knees, this is another one where you have greater than 10 degrees when the knees are locked backwards. Okay. And the thing that's really impressive is every person here that's doing this palms to the floor with their legs extended are over the age of 50. Okay. So this is when we get old and tight. These patients have been this flexible. Legs are perfectly straight. And you get a point for that. So point for each elbow, point for each knee, and point for hands and foot. That's 9. So the next question is how active? You know, we all heard of Flo Hyman, who was on the 1984 Olympic team in volleyball and died in Japan from Marfan's, from a dissection. You know, I've treated many Olympic and pro athletes that have Ehlers-Danlos. When I was at Notre Dame, I was caring for an assistant basketball coach at Indiana University South Bend, who surprisingly had a brother and father who died of aortic dissection from Marfan. He was diagnosed with an aortic enlargement and had his whole aortic root and descending aorta replaced with a Gore-Tex graft, and was still allowed to play Division I basketball. That's a pretty bold sports medicine physician to let someone play with that type of graft. But this was about 15 years ago. So we did a study here about 20 years ago. 1,400 questionnaires were sent out to the patients that I had treated. They got a 205 response, so a pretty poor response rate. But the interesting thing was how many of these patients, obviously predominantly female versus male, were respondents of the 196 that we included. How many were, what type of EDS? You could see 11% didn't know what type they were, 7% were vascular, 25% were classical, and 52% were hypermobile. So how active were these patients? The age range of the patients we looked at, 5 to 75 years old, 17% swam, surprisingly, high school, college, or recreationally. 26% exercise on a daily basis. And this is old data. This is 20 plus years old. 43% exercised at least 2 to 4 times a week. 16% did no exercise. So these patients are active. Okay, these are EDS patients. So you know we know that they've got a higher risk of aortic pathology and valvular pathology, but they're out there exercising, which is where I came into play. Published this on Ehlers-Danlos in athletes back in 2000, I believe it was 2006. So why don't we determine these? I'm gonna sort of blow through this because this is more than this talk about genetic stretching, muscular mass, age, and collagen, determined flexibility. You know what? Let me see. Go back one here. Well, so what do we like them to do? You know, very simple things that are not going to increase their systolic blood pressure too much. And we talk about how to do that. With cardio training, we tell them what not to do. We look at different flexibility and core strengthening when I'm working with my patients with EDS. And these are whether they're athletes or not. We keep their BMI at a certain rate. We keep their weight and the percentage body fat at a certain rate. My skinny minis and my chubby wubbies do the worst with EDS. They have to have a certain kind of muscle mass to control their joints. We don't want them to be competitive in certain sports. Cheer, gymnastics seems to really tear them up, even though they're naturally good at it pre-puberty. You know, the thing I would close with is, you know, just do it. I mean, I try to get them, they're very fearful. They've been told by physicians and geneticists, don't do this, don't do that, don't do this. They're very fearful. They have a lot of psychological overlay. Many of them put on narcotics for pain control. So I say be compassionate, motivate them to remain engaged and active. I usually have a program where I'm getting them volunteering with different organizations with people much less fortunate than they are. Because if anything makes people feel more satisfied with their life is taking care of people less fortunate than them. So I exercise every day, laugh every day, and help someone less fortunate than yourself. I make them all read this book, Pain, the Gift Nobody Wants. If you haven't read it, it basically talks about pain as a gift. And we in America do not really do a great job on teaching our patients to live with pain. And we set goals. And Paul Brand was an orthopedic surgeon trained in Britain and did a lot of work in India with lepers and leprosy, Hansen's disease. And from there, I won't talk too much about the screening because I think that's pretty much talked about already. The genetic testing, I will mention that we are going to have some groundbreaking stuff that our manuscript is ready. I partnered with Medical University of South Carolina. We have a data registry of about 5,000 patients with EDS, and that should be published in the next month. I'll skip my recommendations. They'll be in my slide deck, so I've gone over my time. And one of my cases I wanted to present was a recreational cyclist who fell off his bike, sustained a large flank hematoma, AC separation, chest wall contusion, and this was his X-ray in the ER. And you can see the aneurysm there, large aortic arch. He had a normal EF, minimal MVP, no MR. He was positive for the COL3A1 gene, which is for vascular type EDS. He had open repair of the aortic root, ascending replacement Gore-Tex graft as of 2005. So this was 18 years ago. And he developed a pneumothorax during his post-op, requiring rehospitalization, acute case of development. He recovered, and I lost him to follow. I'll stop right here since I've gone over. I've had other cases. You can read through them. I want to be cognizant of other people and their time. Is that okay, or should I stop?
Yes, thank you. That was excellent, Dr. Lavallee. Thank you so much.
And you can just my slide deck's available, and people can go through different Olympic athletes that I've cared for with EDS and Markins.
Yeah, that was perfect. That was very interesting. Thank you so much.